Good morning, everyone. Thank you, Marcus, for the presentation. I would like to start this lecture by thanking InVibio and the EAO for inviting me to be here. Hopefully, they won't be regretting this afterwards. But my objective here today is to pick up on the presentations by both Dr. Carlos Moura Guedes and Mr. Antonio Silva and place it in the context. So we'll be discussing and interpreting some of the results that were presented here today. The potential of peak infrastructure for achieving and maintaining successful results. There's a second part of this title, which is past, present, and future. So let's start with the past. This year is the 20th anniversary of the inclusion of the first patient in the all-on-4 mandible study that was published in 2003. And no problems in giving credit to who deserves it, to both this man that envisioned what it is the all-on-4 and turned it into what it is today, but also Professor Bo Rangert, at the time Chief Scientist of Noble Biocare, for opening the doors in Noble Biocare to take on the concept and help improving it. And also, this kid should be thankful because it was just a random kid humping around and was lucky to be at the right place at the right time. So the results in 2003 were these: 98.2% survival rate after 1 year. We were very excited about this result. The dentistry community, not so much. And then 2 years later, in 2005, we published the maxilla study. And we also got good results. We were thrilled with these results in the maxilla. But the dentistry community, not so much. And so this is for the past. I said not so much because Dr. Maulo, when he was lecturing in the congresses, he took a lot of criticism, and they were entitled to do that because how much conclusions can you take on 1 year results? Difficult. But let's jump to the present. In the present, I would like to show you some results that we are going to publish still this year, which is the long-term follow-up of the all-on-4 concept. In the mandible, as you see, we have up to 96% cumulative survival rate, implant cumulative survival rate at 10 years, and 92.9% at 15 years. What about the bone loss? Well, in terms of marginal bone resorption, we have an average of 1.72 millimeters at 10 years and 2.45 millimeters at 15 years. What about the maxilla? Well, in the maxilla, we had both a little bit shy of 95% implant cumulative survival rate, and also excellent results in terms of bone loss with 1.19 millimeters at 5 years and 1.61 millimeters at 10 years. So, in my opinion, very good results. But how do you maintain these very good results in the long term? There are some assumptions that we have to take here first. First of all, you need high-quality material. Second, you need high-quality clinicians that can restore properly the case. Third, high-quality technicians that could make the job done, produce and maintain. And fourth, preferably high-quality patients. And this one came after a discussion with Dr. Carlos Moura Guedes that said, Miguel, you also need high-quality patients. And I said, yeah, okay, I agree 80% with that because you don't get to choose if you have an high-quality patient or not. Because usually in our studies, we don't include what we call superman and superwomen. We include consecutively all the patients that come and seek treatment. We don't include just the non-smokers or the non-bruxers or the non-systemically compromised. We include everyone. But really, we need to make a clear difference between what is all on 4 or 4 on all. See, I'm talking about all on 4, the classic distribution of 4 implants, 2 anterior straight implants, 2 posterior distally tilted implants. I'm not talking about the landscape, or by the way, an ugly landscape. So don't try to put everything in the same bag when you're talking about the all on 4. Or is it that we are just asking the wrong question? So also, on the other end, don't put us the tag as fundamentalists of trying to only rehabilitate everyone with 4 implants, because it's not true. We are perfectly comfortable in recommending 6 implants in full bone volume, or the all on 4. But the issue is, when severe atrophy sets in and you start seeing implant support moving anteriorly, then you need to do something. And that's not 6 implants, because you lose the support able to support the last implant, for example. And so you have to start moving. As you see, the implants are moving anteriorly for support, up to a point where you only have bone between the canines to place standard implants. Okay, in that case, then we may add a zygomatic implant and do a hybrid rehabilitation. Or up to the situation where you don't have any bone. And then we place 4 extramaxillary zygomatic implants. Or do a bone graft. So no fundamentalisms here. And sometimes you have to rehabilitate a little bit beyond what you're used to. This is maxilla and beyond, maybe. As a case of a patient that, due to oral cancer, didn't have enough bone to place any implant. And so we were able to rehabilitate the patient with 4 extramaxillary zygomatic implants, up to today. And this is the CT scan, so you can see what we had and how the patient is now. So we're talking about the all on 4 maloclinic protocol. When we discuss this in congresses, everyone usually speaks about surgery and prosthodontics. And for me, the all on 4 concept is a 3R monster. And I always ask, what about maintenance? Maintenance is key to maintain your excellent results that you achieve when you place the definitive prosthesis. But I'm not going to address in this lecture what I usually call old school maintenance, which is show your patient how you brush and how to floss and how to maintain his self-care. We're not going to discuss this here. We're going to discuss our approach for maintenance that includes that aspect, which is very important, but also the epidemiological approach to managing short-term and long-term threats to success. Because when you place the definitive prosthesis, everybody's happy. The patient is happy, the surgeon is happy, the prosthodontist, the dental hygienist, the dental technician, everyone is happy. But then there is a whole lifetime to go, and time and exposure to risk factors that may threat your success. How do you envision your prosthesis in 10 years' time, or 15 years' time, or 20 years' time? We're going to discuss it. Some people think that the way to success is taking the highway. It isn't. It is a very curvy road, and we have to go step by step past each and every checkpoint so that we reach this success that everyone is aiming. If we don't get to one of the checkpoints, then what happens is it's enough for you to get lost on the road, and simply, after this happens, success usually is nowhere to be seen. I love this graphic from Tonetti. It's almost 20 years. Here you see that on the x-axis you have the hazard ratio, and then you have time. Over time, he stated that it seems to have a higher hazard of losing an implant when you insert it, and this hazard ratio tends to go down in time. But then as follow-up increases, there's a tendency also for pockets and bone loss to start occurring. I believe this is pretty much consensual. Let's focus on the first half of the graphic. So here we are talking about threats to short-term success, failure in osseointegration. What do you do about it? Usually, the way things are organized at Malo Clinic, the patient is delivered to the oral hygiene department for maintenance. And the oral hygiene department is responsible for that patient roughly the first 4 to 6 months. Of course, always with the guidance and help from the surgical department. And there are 3 main objectives: prevent infection, decrease the patient's discomfort, and induce healing of both hard and soft tissues. All of this to accomplish the mission, which is to deliver back the patient to the definitive prosthetic phase. Oops. We do this by making a strict division into what is the patient's responsibility and into what is the clinician's responsibility, because of treatment warranty. So the patient's responsibility is on self-care and having an adapted protocol with the products that are adapted to him. It's not all the same product for all the patients. Not the same mouth rinse, not the same gel. But the prophylaxis and maintenance appointment, the responsibility of the clinician, we organized it around these curves. Well, basically, we had it before the study was published, but we were very happy to see that there was a scientific publication about the feeling that we had. If you check here, this is the risk frequency analysis. Medical doctors here placing implants and doing immediate function will know exactly what I'm talking about. If we imagine here, like the force that the implant is being grabbed by bone at surgery, here is highest because usually in immediate function we under-prepare the implant site. And then force goes down to a lower peak, which is the passage between for primary anchorage to secondary anchorage, and then reaching a plateau. If you had implants with machined surfaces, then this would be going down a little bit more. If you had implants with ionite surfaces, according to Glauser's study, then you lower a little bit less and reach a plateau a little bit sooner. That is why we organize the maintenance appointments around these curves. So the first one at the day of surgery, 10 days after surgery, 2 months, 4 months, 6 months. And because time is of the essence, and this is not a 3-day course that we can speak with a lot of time, I'm going to wrap up the diagnostic aspect of the appointment in a little video so that we don't lose in much time and keep on discussing. Sorry if you don't like rock and roll. And if it works. Yeah. So basically we do 5 indexes to check the implants, each and every appointment. No, you pull the sound up. First, remove the prosthesis. And now we start evaluating with mobility, Again, suppuration by finger pressure. Then with a plastic calibrated probe, plaque index, bleeding index, and probing pocket depths. We call it the hand. So mobility, suppuration, plaque bleeding, probing. With these 5 clinical indexes, it's very, very hard for you to miss any problem in an implant. I don't want to get into trouble with copyright. Okay, now let's go for the second part of the graphic, which is long-term maintenance. Now, these occurrences of pockets and bone loss, I think we all agree that to be classified as peri-implant disease or peri-implant pathology, the main threat for long-term success. But what about peri-implantitis? Now here we have an issue. We hate the term. Luckily, we're not the only ones. This editorial by Zarb, Koch, and Albertson 5 years ago explained it brilliantly. So they are also continuing to be critical because the term peri-implantitis implies a disease mechanism similar as periodontitis. And teeth really are different from implants. What they propose is not to fill the vacuum created by our lack of knowledge on the implant dentistry with what we already reasonably know about periodontitis. And they end the editorial proposing a conceptual framework based on the tenet that bone loss requires multifactorial model to explain its occurrence. Great, that's exactly what we also think. And we agree so much with this that the study, this editorial was published in 2013. We've been agreeing with it since 2006. But okay, I understand it's different, Professor Zarb, Koch, and Albertson saying this than we saying this, but we're happy all the same. So, name, check. So what's the definition? The definition of peri-implant pathology or peri-implant disease for us is a group of multifactorial situations that negatively affect the implant with intervention from both biological and biomechanical aspects that may act independently or together. The clinical manifestations are the ones that usually are stated. Probing pocket depths over 5 millimeters, bleeding on probing, concurrent presence of vertical bone loss, and attachment loss compared to the last evaluation. And yes, it's true, also here, usually there isn't much consensus on the dental community. You have different definitions with different values as marks. So, name, definition, what's the prevalence? When we attempted to study this situation, there was a big systematic review that concluded that peri-implantitis was found in 28 to 56% of subjects and 12 to 43% of implant sites. And we looked at it and we cannot do much with this kind of range. So we study it. But why is so hard to get a glimpse on the kind of disease that we are talking about? Why so many differences in terms of definition? Why so many differences in terms of approach? Well, basically because there is a limitation in the ability to identify both specific environmental causes and host susceptibility, especially as we believe that peri-implant disease occurs when it's dependent on multiple factors, on long periods of exposure, and on subclinical stages of the disease. And then we go back to our classes in the university and remember this old epidemiologic triad about the host environment and the agent. But there's something missing here. There's a fourth dimension that needs to be here. Can anyone guess what it is? If anyone guesses, I'll give him a candy. I'll put on the music with a friend to help explaining it, if we can go and guess it. The sound, please. Come on. What's the factor missing? Time. Time. So time, sorry, I keep it. So time is what makes this epidemiologic triad move around. Time and the exposure to risk factors. So the solution is an epidemiologic approach, epidemiologic surveillance, which basically you need to place it as a current practice. Do it, collect data, interpret, explain, recollect, so that when you focus on risk sources and pathways of exposure, and also on health outcomes that interest you, you are able to determine on your practice what's your prevalence of peri-implant disease, or your prevalence in caries, or your prevalence in periodontitis. We did it. We calibrated each and every dental hygienist on all clinics in Portugal. We received the information at the headquarters in Lisbon, where we had our oral hygiene department, and basically what we did was we made a record of every patient, of every hygienist, every day, for 3.5 years. We ended up with a sample of 22,009 patients. This was an example, and we collected both information on age, gender, systemic condition, and then chronic and acute diseases. We ended up with more than 800,000 entries in a table to analyze, which we called like the matrix. And when we turned it for the statistical software, it turned into over 1 million entries. But among other things, amongst 3 multivariable models for the major chronic diseases, we got our prevalence of 13.9% at patient level, around 8% at implant level. Okay, so now you have the name, the definition, and the prevalence. What's the strategy to approach the main threat of long-term success? This is the strategy we propose. It's a 3-step strategy. First, measure the risk. Second, manage the risk. Third, communicate the risk. Miss one, miss the entire strategy. Measure the risk. This is about risk factors. We published a significant amount of literature on this subject. We investigated more than 35 variables, and we ended up with our model. Well, remember when we talked about the criticism about the term peri-implantitis? Usually, the term peri-implantitis comes together with that disease mechanism caused by biofilm accumulation. We did not believe that. We believe that there are also biomechanical aspects involved. We believe that this biofilm-mediated response is one of the mechanisms, not the whole mechanism. And if biofilm-mediated mechanism was the major one, it means that it would be on these pies. This is the Sander-Greenland model that explains chronic diseases. For us, peri-implant disease is a chronic disease, so it's multifactorial. And it explains really simple. Pie or pizza. You have different pies or different pizzas with different flavors that can produce the outcome. So every time peri-implant disease was present, on 14 cases, and let me remember that this study was performed with 1,350 patients. Every time there is disease, we collected which risk factors were there. And if biofilm-mediated disease was the major one, it should be on either all of them or at least on the pie that had more cases. Bacterial plague is not here. Is here for the first time. So that illustrates our approach. So what was our model? Our multivariable model was this one. So we involved the variables history of periodontitis, bacterial plague, smoking, bleeding, type of material used in the restoration, lack of prosthetic fit or non-optimal screw joint. This complicated name is either lack of passive fit or loosening of prosthetic components, proximity of implants or teeth, and the interaction of that variable with plaque. What does that tell you? Not much. Then you have the odds ratios here, which reads very quickly that, for example, plaque, a patient with plaque had 3.6 more times the chance of having peri-implant disease than a patient without plaque. Okay, it's interesting to know, but in a model, you don't read the value of the variable independently. You read the final value of the model. But you can do that with the odds ratio. You can do that with the beta value. Now, this you can work with on prognosis. How? So, first you have to get your geek mode on, okay? Voila. So, with geek mode on, you just solve this logarithmic equation, and then you end up with a model with a high sensitivity and specificity that will pinpoint correctly which patients are at high or low risk of peri-implant disease with 96% accuracy. Very good. But you need to be a geek for this. It has its advantages. So, with geek mode off, what if we made it a little bit more user-friendly and turn this into risk score points that you can sum and then get a final result, get your risk profile, and manage? That will be a little bit better. But it's even a little bit more easy than that. On this website, for free, you have the access to this tool where you just respond to the questions on periodontitis about the variables: plaque, bleeding, proximity of implants or teeth, type of material used in the restoration, lack of passive fit or loosening of prosthetic components, bone level, and smoking. And then when you hit finish, the system will retrieve the score points, the risk profile, the recommended recall regimen, and you can even download the PDF and give it to the patient for him to work on it and improve his risk score. So this is measure the risk, manage the risk, communicate the risk. The future. Past, done. Present, done. Future. Well, the future starts now. Actually, it already started. It started with the publication of the study in 2018, this year, with the one-year results, plus the two-year results that were also discussed by my colleague, Dr. Carlos Moraguete. What we are talking about here is an implant cumulative survival rate of 100%, a marginal bone loss on average 0.37 millimeters, incidence of peri-implant disease of 0%, and an absence of correlation between plaque and bleeding. We are going to discuss these results. First, implant survival 100%. Yeah. Okay, it's just a 2-year, right? So I went to check, if you recall the long-term graphics, I went to check it, and we're here, right? And here in both maxilla and mandible, we had, at 2 years, 99.1% survival for the mandible, 97.9% for the maxilla. So it seems promising versus 100%. What about marginal bone loss? Well, besides the excellent result in marginal bone loss after 1 year, what was interesting was to observe that cases of bimaxillary rehabilitation actually had an average marginal bone loss which was lower than the single arch rehabilitations. So maybe there is something here working on shock absorbing that may influence this. Of course, my conclusion is empirical, rather clinical. But we'll have the follow-up to check that. And what about the correlation between plaque and bleeding? This correlation represents a landmark in implant dentistry, especially on maintenance, because Pontoriero in 2001 replicated a very old clinical trial by Harold Lowe in the 50s, which was to test the influence of plaque on bleeding. Harold Lowe did it on teeth, Pontoriero replicated it on implants, and then Professor Salvi made this recent not recent, 2011, but a more recent publication concerning the same aspect. So what happened? We're expecting that plaque and bleeding have a positive correlation. The higher the plaque levels, the higher the bleeding levels. That's what we're expecting. And if plaque levels go down, we expect that bleeding levels also go down. So Professor Salvi picked up a sample of 15 patients with excellent oral hygiene levels and told them, stop brushing and flossing for 3 weeks. And then after 1 week, he went and measured. He measured modified plaque index and modified bleeding index. These indexes are done by Mombelli and colleagues. They score very easily between 0 and 3. For example, in plaque, 0 is no plaque, 3 is you can guess what he had for dinner last night. A 1 in plaque is a plaque visible only after performing the movement with the probe inserted 1 millimeter into the sulcus and running a circle. And the 2 is plaque seen by the naked eye. The same with bleeding. 0, no bleeding. 1, isolating bleeding spots. 2, the blood forms like is confluent on the margin, like a ring. And 3, heavier profuse bleeding. The results were these. After 1 week, you had plaque, 1.17 on average, and 1.33 on bleeding. So, okay, both increasing. At 2 weeks, a little more increase in plaque and stabilization on bleeding. But at 3 weeks, with the same plaque level, more bleeding. So this is an example of a positive correlation. At 3 weeks, they did prophylaxis and the patients got back to their old habits. What happened was plaque levels dropped and so did bleeding levels. The mucosa takes a little bit more time to adapt. But what happened in our study? In our study, we started with a positive correlation, statistically significant, despite not that strong. But yes, the higher the plaque, the higher the bleeding. But at 1 year, the plaque levels increased. Well, this is something that we are used to see because on the first evaluation, the patients are on their toes. New prosthesis, new rehabilitation, everything is perfect. But slowly, they move down to their routine oral hygiene habits over the time. But bleeding levels were the same, and there was no correlation. So maybe something is preventing here the inflammation. I'm not going to take that conclusion straight away, but the fact that the peak cylinder is placed right in contact with the mucosa, it's not innocent. So this is the illustration of what we had in the first 6 months and what we had at 1 year. So you can see plaque without doing anything, but the bleeding levels don't match the same score. Okay, then what about peri-implant disease? What's the contribution that PEAK may give to the risk model for peri-implant disease? Well, first of all, let's talk about what is not going to be contributing. It's not going to contribute with history of periodontitis because the patient's already had it. And in this case, it's not going to contribute for the proximity of teeth or implants because these are full arch cases. And also, they won't teach the patients to brush better. And you saw that bleeding was also present. And sorry, but they won't help your patient quit smoking. But they will impact here on the lack of passive fit and non-optimal screw joint. It is CAD-CAM processed. And also, PEAK has a different versatility to dance around in all occlusion schemes. Also, the bone level, which is very far from the median third on average, as you saw in the results, average of 0.37 millimeters, and the type of material that you use on your prosthesis. So we're talking about 2 to 8 points of prevention. It's a lot of points and a lot of prevention. Illustrated by our result of 0% in the incidence of peri-implant disease. And you go, 2 years follow-up, calm down on your conclusions. True. But we went to check what happened on the long-term studies. We know that the tendency for peri-implant disease is to increase over the follow-up time. But from the 20 to 23% of peri-implant disease incidence rate that we had on these studies, at 2 years of follow-up, we already had 3% implant-related rate in the maxilla and 2.1% in the mandible. Patient-related, almost 10% in the maxilla and almost 5% in the mandible, versus 0% here. So, promising. So, is it all rainbows and butterflies? No. What about if something goes wrong and peri-implant disease really happens? Then you start to talk about prognosis. And the issue with prognosis this decision that you have to make with the implant that you have in front of you, should it be saved or removed? You agree that today it's pretty much dependent on your judgment. We wanted to study and have a multivariable model to try and help that decision. So we did a study from the patients of epi-surveillance study, and we collected data on the diagnosis. We followed them for 1 year, and we did a multivariable statistical analysis. And here, we studied more than 20 variables. And we got to a point where we were able to retrieve a model again. And once again, with your model, but with geek mode on, you're able to solve this logarithmic equation and have a model that will have an area under the curve of 0.763. What does it mean? It means that we'll pinpoint correctly in 1 year if the implant has a reincidence or a failure or not, and we'll pinpoint correctly 3 every 4 times. Well, it's not the best, but it's better than flipping the coin, right? Maybe not? Okay. So transforming this into a more user-friendly model, we got the model with age, measured in years of life, the presence or absence of history of periodontitis, bone level on the implant's middle third, the development of disease in the first 4 years of follow-up, and implant length over 13 millimeters. These were the variables, the risk indicators. In order to try and change this into a certainty. So as a illustration, you have the baseline radiograph of a patient where implant 11 had the bone level located on the implant's fifth thread. We tested on this patient. It was a 65-year-old patient with presence of history of periodontitis. The implant was already on the middle third of the implant, the bone level, sorry. It was developed in the first 4 years, and the implant was an 11.5 millimeters of length, so this is 0. And what happened is an 80% unfavorable probability of, in 1 year, either having a reincidence or a failure of this implant. And 1 year later, what happened? It happened that the bone loss progressed from the 5th to the 9th implant thread. So we were able to correctly guess in this situation. So it's just another tool. How could PEAK impact this model? First, it's not the new youth elixir, so it won't make your patients younger. And again, it won't help on the history of periodontitis. But as you saw in the, and also the implant length, I'm sorry. But as you saw previously, the bone level is really, really, really far from the implant's middle third. And, well, fingers crossed, we're halfway through the early disease development with this 2 year of follow-up. Promising. So, wrapping up, in summary, with an absence of correlation between plaque and bleeding, low marginal bone resorption, low incidence of complications, and an absence of that correlation between plaque and bleeding, this, in my opinion, translates into a good prognosis for the long term. But of course, that more follow-up is needed. Hopefully, we'll be publishing next year the 3-year follow-up of this situation. And if we recall the message last time we were together in Madrid, the message is still accurate. When you place the final prosthesis, everyone is happy, but then there's a whole lifetime to go, time to be exposed to risk factors. And the way you answer the question about how you foresee your prosthesis in 10 years or 15 years that I did in the beginning of the lecture is really simple. If you were a street car racer, you would live your life a quarter mile of the time because the quarter mile is the length of that race. But we are not street car racers, we're clinicians. So as clinicians, we should live our lives a recall schedule at a time. So the way you foresee your prosthesis success in 10 or 15 years' time is not to worry about that. It's worried about today and plan for the next appointment, each and every time. And when you go back at it retrospectively, then you'll find your success with 15 and 18 years. That's the real success, not the success that is shown when the definitive prosthesis is placed. That one is not that difficult to achieve. And yes, this message is also still accurate because my faith didn't change since last year. For me, PEAK may be the next periodontal ligament. Thank you very much for your attention.